Ethical challenges associated with digital or electronic medical imaging. Ethics and professionalism are fundamental in providing good radiographic practice. Radiographers, radiologic technologists, must develop and maintain an adequate knowledge of key components of the laws and regulations that affect their patients and practices. The law does not always establish positive duties. To the extent that professional ethics do. The current understanding of professional ethics is based on the principles from which positive duties emerge. Professional ethics creates a basis for radiographers' work, as it includes values and principles, together with rights and duties that guide and support professionals. However, little is understood about radiographers' rights when it comes to professional ethics. Radiographers must treat all individuals with respect, dignity, and without discrimination, providing care regardless of race, culture, national, social, or ethnic origin, color, gender, marital and family status, sexual orientation, religious or political affiliation, language, age, type of illness, mental or physical abilities. In other words, we need to treat everyone equally and with respect. Radiographers should make use of appropriate professional, institutional, or regulatory mechanisms to intervene when they are witness to abuse or unsafe practices. The most common ethical issues associated with medical imaging radiographers are not explaining his or her experience during their introduction, the radiographer's expectations of the patient, how the procedure is to be performed, and getting patient consent. Why is there a need for radiologic technologists to study ethics? Let me give you a few phrases you may have heard in your department that can demonstrate why we need to study ethics. One is, have you heard? Another might be, well, that's all the radiologist needed to see. Another is, it's okay, it'll work, let's not repeat it. As you can see, there are many ethical situations that happen constantly in radiology and medical imaging. Imaging and radiation science professionals face a variety of ethical challenges within medical imaging services. They interact and communicate with not only other healthcare professionals, but patients and family. A firm grounding in ethics may help imaging professionals, radiation therapy specialists, and other healthcare professionals respond positively to the dilemmas they encounter in the workplace. Healthcare is in the midst of a transformative change. It is undergoing reform through initiatives that focus on improving patient outcomes with computer-based technology. Providing healthcare is a complex activity, which needs many different types of professionals with different knowledge, skills, and competencies with specific roles, and there is a demand from the public for these professionals to act ethically. Those in healthcare must change some outdated attitudes and practices regarding technology and social interaction. Change comes about through understanding the need for change. The evidence-based medicine algorithm is a standard of practice today. This means using the most up-to-date scientific research data that has been analyzed and accepted as fact. We must also be able to communicate this data and utilize it ethically. In healthcare, some common ethical issues include confidentiality, data security and technological reliability, consent, competence, interprofessional and professional patient relationships, and the organization of medical services. This presentation is designed to communicate the basic principles of ethics for healthcare professionals, especially those working in medical imaging. Some ethical lines are clearly drawn and hence crossed rarely. Others, however, are blurred, and the distinction between right and wrong is not quite clear. So today we're going to look at the 4 principal pillars of ethics. Autonomy. People have the right to control what happens to their own body. Beneficence. All healthcare providers must strive to improve the patient's health and to do the most good for the patient in every situation. Non-malfeasance. First, do no harm is the bedrock of medical ethics. In every situation, healthcare providers should avoid causing harm to their patients. And justice. The 4th principle demands that you should try to be as fair as possible when offering treatments to patients and allocating some medical resources. In this presentation, we'd like to focus on values, moral principles, ethical practice, rules of conduct, rules and regulations, and also research into ethics. Ethical responsibility ultimately rests on the agent. The term agent not only refers to the doctor or technologist performing the action, but can also include the professional and regulatory framework surrounding it, and corporate and regulatory bodies that are responsible for the agents. The defining characteristic of medicine in recent times has been its immense scientific and technological success, coupled with an iconic repositioning in public consciousness. This has been accomplished by growth in expectations from hospitals and medical institutions to a level where they are unrealistic and place undue burden on the healthcare system and those working in it. This also inevitably creates a public disappointment and anger when expectations are not met. Often conflicts are just poor communication, and what we look at with ethics is being able to resolve the conflicts. Unethical collection of money or healthcare frauds for Medicaid and Medicare are in the news constantly. As a healthcare professional, you should be aware of the agent or the facility or system that you are working for, because these frauds can end up causing the patient's money and you jail time. Here we see a report that was done by the Department of Justice in the year 2022. The FBI and the California Department of Insurance Fraud Division investigated this matter. The CEO of several Southern California-based medical imaging companies was sentenced today to 60 months in federal prison for running a scheme that submitted more than $250 million in fraudulent claims through the California Workers' Compensation System for medical services procured through bribes and kickbacks to physicians and others. Is this an unusual circumstance? Actually not. A few decades ago, when I was director of radiology in one of the hospitals here in Texas, I had a similar situation in that I had a OBGYN that was reading the preliminary ultrasound to get an accurate date of the delivery and then ordering an ultrasound later. When you order a ultrasound late in the pregnancy, you cannot be as accurate as to the delivery date. You start getting into plus and minus. This physician then did a number of C-sections, and I got a complaint from the surgery department that our ultrasounds were inaccurate, which caused these C-sections to be accomplished. As I said, I had to go back and explore this, and it was a very difficult matter to get this done, both exploring with the hospital and other healthcare professionals, including some very prominent physicians. Talk about the old axiom, the fox is guarding the chicken house. Congress has been charged with a high-stakes, high-wire balancing act to create a bill preserving quality and access while trimming unnecessary, unethical, and unnecessary spending from the medical budget. Medical imaging represents such a challenge, with its undeniable benefits tainted by inappropriate use. In discussing this with one of my radiologist friends, what I found is he was telling me too many unnecessary or repeat exams are performed. Inappropriate utilization that forms the bad trio. That's the reasons for inappropriate imaging, the bad trio. What are they? Fear of malpractice, lack of knowledge about when to use imaging, and incomplete clinical examinations prior to requesting an imaging study. Medical imaging professionals should not carry out a procedure that may be considered dangerous without first confirming instructions for the procedure with the person authorized who has made the request and satisfying themselves that the instructions contain no error and that they can safely, or as safely as possible, proceed doing the examination. Being a radiographer means being very cautious and careful with instructions. It is especially important to follow the existing code of ethics once a patient and a radiographer do not speak the same language to avoid confusion. It is admirable to try to communicate with your patient, especially using their own language when possible. But you should also understand their culture so you do not give offense when trying to communicate. We can hear people that only have English as their basic language often say things to patients such as respiri undo e retengulo, no respiri, no resuea, ya respiri, or hijai kal mak mak, la yut set leo. Both of these sentences have meaning for a basic chest x-ray. But being able to say the words and communicate them are two different things. An understanding of custom and culture is essential. Many so-called ethical conflicts in medical ethics are traceable back to a lack of communication. Communication breakdowns between patients and their healthcare team, between family members, or between members of the medical community can lead to disagreements and strong feelings. These breakdowns should be remedied, and many apparently insurmountable ethics problems can be solved with open lines of communication. It is good to have a knowledge of the cultural values of the population that you work with, or when you're in another country or another situation, be aware of their cultural values which may differ from yours. A humorous example of this is when you go to Italy, the gesture we use here in Texas at the UT during a football game, the old hook 'em horn signal, is considered impolite. A person from Italy seeing a stadium full of UT fans doing the hook 'em horns would be aghast at the gesture. A more serious example would be working with a Chinese family wherein the family makes the medical decisions over the patient, and you need to defer to the family and communicate with the family as well as the patient. There is a difference between morals and laws. A law may be moral or it may be immoral, but it is a regulation that is provided by governments. Morals are accepted customs of living by right and proper conduct and an individual's practice in relation to the customs of others. All professional decisions in radiologic sciences and other healthcare practices involve a consideration of human values. Unethical behavior that is clearly wrong can be defined as an ethical outrage. Ethical dilemmas occur when the correct choice is not clear and personal values may conflict with ethical values. Ethical dilemmas require an ethical analysis. There are many basic ethical theories and principles, but almost all professional codes of ethics are based on beneficence or the active doing of good. The good of an activity is evaluated based on whether immediate harm is balanced with any future benefit. We know this as consequentialism, where decisions are based on the consequences or outcomes of a specific act. Confidentiality is commonly applied to conversations between healthcare providers and patients. Legal protections prevent healthcare providers from revealing their discussions with the patients, even under oath in court. Patient confidentiality is mandated in American laws stemming from the Health Information Portability and Accountability Act, or HIPAA, specifically the privacy rule and various state laws. Some are even more rigorous than HIPAA. It is clear that communication is both vitally important and potentially perilous in the practice of healthcare. Those who are guilty of gossip, thoughtless sharing of confidential information, inaccurate reporting, or incorrect medical recording often cause serious consequences for the patient as well as the professional or legal problems for themselves. Radiologic technology is a science. The medical imaging professional technologist must not only meet the requirements in knowledge, but demonstrate the ability to apply that knowledge, including upgrading their proficiency and understanding levels as technologies advance and evolve. This should all be done in an ethical manner. Digital medical images are created from data that is acquired from the interaction of energy with the patient. This data can be reconstructed in many ways. We can take individual pieces of data and look at them very specifically, or we can look at different combinations of data. How we reconstruct the images does not require us to irradiate or expose the patient, but the one time. This is where all the data is gathered. Remember, digital images are a capture of the information at a specific time and place. We use different digital techniques and different modalities, whether it's an ultrasound unit, a CT unit, a mammography unit, or a diagnostic X-ray unit. All of these require us to make choices, and these choices need to be ethical choices or governed by professional ethics. A digital image is not an exact picture of reality. It is only a discrete approximation based upon the data capture and software reconstruction of that data. The modality used, the exposure technique, and region of interest demonstrated determine the data capture. How data is displayed and manipulated depends on the information requested by the viewer. The same data can be reviewed many times and displayed in many formats. One of the ethical problems that is encountered by all medical imaging professionals using different modalities or imaging capture techniques is that the modality and the software used for construction of the images is proprietary and known to the vendor. They only share what they must. This makes it very difficult because each vendor wants to sell their own equipment. Therefore, all the equipment will differ, and all of the techniques of what the equipment can do will differ, even among the same manufacturer. Digital images emulate traditional analog images or the old film screen images. When we talk about quality with digital images and quality of a film screen image, we're looking at apples and oranges. We're looking at two different things. But the one thing that is in common with both is the person's perception who is viewing those images, and the subjective perception is in the eye of the beholder. Image quality is defined by an observer's ability to achieve an acceptable level of performance for a specified task. It would be beneficial if the medical imaging professional had the ability to go into the software programs, but the status quo is that raw data are largely inaccessible and usually in a proprietary format. Manufacturers have built their business models on this type of data architecture, assured that their products are compliant with regulations, and have learned to compete and innovate in this environment. Today's medical imaging is totally different than film screen imaging of the past. In electronic imaging, the functional parts of conventional medical imaging have been separated out. We now have three distinct areas. 1, image capture. 2, image storage. And 3, image display. No longer do you put a piece of film on one side of a processor and have the end product drop out the other. One of the big differences between digital image and film screen imaging is that with film screen imaging, we had an end product. With digital imaging, we can go in and reconstruct images at any time. We can post-process the data to reflect different information. One principal characteristic of digital imaging modalities is the drastic increase not only in the number of images they produce, but in the amount of data per image that is accessible. Today's imaging modalities can not only get diagnostic images, but also data about the tissue that they are imaging. This allows the physician to have more information to make a diagnosis or to treat a medical problem. When we take a look at patient diagnosis and the ethics of the diagnosis, we have to look at the ethics of utilizing each of the modalities. We have a number of modalities that we can use, and the idea is that if we can use a modality that does not use ionizing radiation, it is safer for the patient, such as an ultrasound examination. We do choose the modality based upon the end result that we can get from using that modality and the information that is required to treat the patient. The difference between film screen capture of imaging and digital capture of imaging is that the digital medical imaging is indirect and often counterintuitive. The process of capturing the data, understanding the data, and manipulating the data to create an image is different for each modality. With film screen imaging, we got an image product. We would evaluate the image product, and if it did not meet our needs, we would have to repeat the image. With digital imaging, we get data, and with that data, we don't have the same analysis that we had with a film screen image. With a digital image, we have a loss of visual clues. We have a very wide dynamic range. We have automatic rescaling of the exposure. We have different types of imaging processing, and the relationship in setting up technique factors is totally different. MAS or mass is not any longer density divided by brightness and control, and KVP is no longer just contrast. We need to understand KVP, KEV, photoelectric effect, and characteristic radiation, and how they can be applied to get the best data to create the image. Imaging physics and the fundamentals are more critical today than they ever have been in the past. Today's imaging professional is just not producing an outcome. The imaging professional of today must be able to visualize the entire process. Things are very different from when we had film screen combinations to digital imaging. Unique perception based upon knowledge and experience help us to create these images. We need to build on our skill and expertise of the past and prepare for the future. Today's radiographer needs not only the skills required of a film screen radiographer, such as positioning and technique, but also the understanding of an IT specialist. With that in mind, many people go, wow, we can go to artificial intelligence and robots, because it has been proven that artificial intelligence can actually do better at interpreting the data than a human being, and that robots are much more efficient than human beings. But in fact, there is some applications in medical imaging that make it more of an art than a science. And one of the biggest applications that makes it reliant on humans is the ability to have empathy with the patient. There's so much electronic information out there, including medical imaging, and the amount of this data is only projected to grow. Nobody can ingest it all, and nobody can utilize all the information. So one of the ethical dilemmas we have is deciding on how to appropriately use the information and the technology we have for medical imaging now and in the future. One of the biggest parts of our dilemma is the amount of technology we have, the different types of technology we have, and the utilization of the technology, plus the interpretation of the information that we get from the technology. And this is just in medical imaging, let alone the other resources available to the requesting physician and to the radiologist to research what he needs to know to interpret the image correctly, or she needs to interpret the image with the information that is available beyond medical imaging. This image demonstrates some of the processes involved in getting a medical imaging report and diagnosis. We begin with the patient record. We then would schedule a medical image using the appropriate type of modality. We would then get the image, get the data, put it all together, and then process the data and post-process the data to create the images that we need to read or interpret. The interpretation is based on the perception of the person that is doing the interpretation. There is a difference in the skill set and knowledge base between a radiographer, a radiologist, and a referring physician. We need to have some reasoning as to how to ethically utilize this information and create a report and communicate it to the patient. Beginning with Conrad Röntgen and Marie Curie, we have been imaging for almost 2 centuries now. Over the past 120 years, the use of X-ray and gamma ray in medicine has led to the development of other types of imaging modalities, such as ultrasound, magnetic resonance imaging, and elastography. Measurable digital imaging parameters has taken medical imaging beyond organ anatomy and pathology into the realms of physiology, pharmacology, and cellular and molecular biology. Speaking of ethical dilemmas, it's amazing to think that the original anatomy was a problem ethically, where grave robbers had to bring in some bodies that had to be dissected for the physicians to understand the anatomy and physiology of the body. Today, we can get very precise details about anatomy and physiology through medical imaging. We can not only look at the anatomy, but we can also manipulate the image to demonstrate different aspects of the anatomy, giving us a much broader perspective of what the process is in the disease process that we are trying to cure. Beyond the simple acquisition of images with film screen that we did in the past, where we had poor or low resolution images on a plain film, today we can actually do digital imaging, we can do 3D digital imaging, we can do 4D digital imaging, which then shows us both time and motion as in a movie, and finally we can do 5D, so we can look at blood flow and fluid dynamics. So we range from an original 2D planar image all the way to a 5D image to get our information in treating the patient. Healthcare is a complex activity and has changed remarkably. No longer do we just have the old X-ray department, but now we have an imaging department. Not only do we have radiologists and radiographers, but now we have other healthcare professionals also using imaging modalities, including physicians, ultrasonographers, cardiologists, interventional physicians, and many more. Medical imaging has gone beyond just a facility and the people at the facility. This has caused a lot of ethical dilemmas based upon now everyone has access and communicates with the physician for the patient's health care. This may be a radiologist who is using teleradiology so that they can cover 5 or 6 hospitals in their area or even in a different country. This may be a physician who is doing some of the surgery at one facility remotely via computer. In medical imaging, acquisition and display systems, there are many parameters specific to the various imaging modalities that have an impact on the observer's ability to make the diagnosis accurately. You must understand how we're able to use the display system and communicate images to be able to get the correct image and the correct interpretation. Teleradiology is the electronic transmission of radiographic images from one geographic location to another for the purposes of diagnosis or consultation. Teleradiology raises interesting ethical and practical issues which have received a lot of attention lately, especially as far as radiology or ethics is concerned in the practice of radiology. Unlike staff radiologists, teleradiology companies often aren't in a position to influence the quality of the images, even though they're taking legal responsibility for reading them. Nor can they offer the physical proximity to get in touch with the sending facility to change the parameters in the image to get a better exam quality. Once you take a look at the complexity of all the interactions, you can see where all of the ethical issues are, ranging from who's reading what to who's getting paid for what, and what is the quality of the exam. But let's start out by doing the definition of medical imaging and go from there.
Structures hidden by the skin and bones, as well as to diagnose and treat disease. Medical imaging also establishes a database of normal anatomy and physiology to make it possible to identify abnormalities. Although imaging of removed organs and tissues can be performed for medical reasons, such procedures are usually considered part of pathology instead of medical imaging. As a discipline and in its widest sense, it is part of biological imaging and incorporates radiology, which uses the imaging technologies of X-ray radiography, magnetic resonance imaging, medical ultrasonography or ultrasound, endoscopy, elastography, tactile imaging, thermography, medical photography and nuclear medicine functional imaging techniques as positron emission tomography, PET, and single photon emission computed tomography, SPECT. Measurement and recording techniques which are not primarily designed to produce images, such as electroencephalography, EEG, magnetoencephalography, MEG, electrocardiography, ECG, and others represent other technologies which produce data susceptible to representation as a parameter graph versus time or maps which contain data about the measurement locations. In a limited comparison, these technologies can be considered as forms of medical imaging in another discipline.
From here forward, we're going to talk about balancing money, quality, and time, and how we balance those against ethical considerations to create a medical image. The cost of allocation of resources often impacts on the ethical choices that we make. We'll begin by looking at monitors for display of medical images. We have three different distinct levels of display monitor for medical imaging. We have a diagnostic monitor, a QC monitor, and a referential monitor. Each of these monitors has a different resolution and cost, and each has a difference in display that can be visualized. It would be ideal if everyone could have a diagnostic monitor, but it is not cost effective. And when we take a look at referential monitors, those are just used up on the floors or throughout our system by people that are not interpreting the x-rays, but looking at the results of the interpretation and other types of documentation. Quality control monitors, or the monitors that the operators use on the modalities, usually do not have the same resolution as a diagnostic monitor to save on cost. At the same time, they do not display the same quality of image. On a QC monitor, you may not be able to see a cancer or other problem that can be easily displayed on a diagnostic monitor, which the radiologists or other interpreting physicians use to diagnose the images. We acquire a medical image signal and we convert that signal into data. What is the cost of transmission and storage of that signal? Is it ethical to change the data to make transition and storage more efficient and less costly? In signal processing, data compression, source coding, or bit rate reduction is the process of encoding information using fewer bits of information than the original representation. Any particular compression is either lossless or lossy. A lossless compression reduces bits by identifying and eliminating statistical redundancy, where a lossy actually loses data. Here's where the ethical choice comes in. The ACR, American College of Radiology, technical standard for digital imaging data management does not specify an acceptable compression ratio, and this is left to the discretion of the qualified physician. Lossless data is data that is the original data. Lossy compression keeps the original data that is germane and reduces redundancy. Lossless compression does not change the original image, but rather it changes the compression factors from 2 to 4, meaning that we cannot get the original data back, but we have not lost data that would have impact on the image. Lossy is irreversible compression with some loss of information, or lossless is reversible compression with no loss of information. So here is the dilemma. When we're talking about lossy versus lossless, we're actually taking out data that we couldn't see anyway on the X-ray signal. So we can actually speed up the signal and make it smaller by 10 to 20 times. On the other hand, if you want to be able to see the original data, you would have to use lossless compression. Lossy refers to a compression scheme wherein the image is close to the original after it's decompressed, but not identical. In other words, some information is lost during the compression procedure. The idea is everybody has a unique ability, or vision is subjective. How much can we really compress an image without losing any of the diagnostic information? That is left up to the physician, and that's what makes it an ethical dilemma. Data archiving is data storage. The less data you have to store, the more room you have in the archive. Data archiving is the process of moving data that is no longer actively used to a separate storage device for long-term retention. Archive data consists of older data that remains important to the organization or must be retained for further reference or regulatory compliance reasons. Data archives are indexed to have search capabilities, so files can be located and retrieved expeditiously. Data transmission refers to the process of transferring data between two or more digital devices. Data is transmitted from one device to another in an analog or digital format. Basically, data transmission enables devices or components within devices to speak to each other. The smaller the data transmitted, the faster the transmission. We're next going to discuss creating a diagnostic image. When we talk about ethics, what we can see is this is a complex process and that there are a number of choices that you make during each exam. We want to take a look at making these choices ethically to produce the best image that you can. This has a lot to do with understanding your modality and also the quality control that is associated with producing a good image for the modality. Imaging modalities must be used correctly to acquire good quality images. Select the proper examination. Properly associate demographic and exam information to image. Properly manipulate the detector or image receptor. Review the image before releasing the patient. Know how to recover from errors without repeating the examination. Position correctly and follow exposure factor control limits. And finally, select appropriate factors for patient age and body habitus. Automation of the technology does not relieve the operator of the following obligations: skill in patient positioning, patient communication and instruction, exposure technique selection, both manual and automated, knowledge of the modality to include its idiosyncrasies and ancillary devices, patient care, both radiation protection and clinical tasks, care of the exam room and the equipment. One of the blessings and also one of the traps in providing a quality examination is the reliance on automation and post-processing of digital information. The problems surrounding automation are well known, as are the solutions. Optimization of digital images. The impression that digital images can always be adjusted after exposure with X-rays is not necessarily true. You have to have the correct exposure range. There are several factors affecting the quality of images, and radiographers or technologists are the key persons who are responsible for delivering good quality radiographs with reasonable radiation dose given to the patients. Quality control of the technical parameters and radiographic positioning are therefore critical to a digital image. A common myth in digital imaging is that X-ray techniques or exposure don't matter. You can use whatever you want. The machine will automatically set it. The truth is that images always look better at higher exposure rates, but it is very possible to overexpose the patient. You still need to be able to look at your technique and apply it correctly. Take a look at this medical image and tell me, do you know what's wrong with the image and why it actually came out the way it did? There were several errors in acquiring the image, all of which gave us an image that was not acceptable, but yet this image was submitted in one of the most prestigious hospitals in the United States for interpretation. Here we can observe what image the modality will produce using a software to manipulate the data to try to give you the proper image. Below, we can see what the actual technique was used in getting this image. To the right, you will notice that the exposure has been adjusted by the software in the modality to make it appear that you're getting a quality image. You must know your equipment and you must know the exposure factors to properly get the information that we need for examinations. The modality operator must understand the imaging process for the modality in which they are responsible. Automatic image processing involves assumptions about exposure technique, the composition of anatomic region that is being imaged, and the use of collimation and positioning. A number of factors can interfere with automatic detection of the boundaries of the image field and change the appearance of the image. Post-processing of a digital image should be used for the purpose of improving the usability of the image. This includes imprinting demographic overlays, adding annotations, applying borders and shadow masks, flipping and rotation of the image, increasing magnification, conjoining images for special examinations like scoliosis, and modifying the sequence of views. This process will require a separate QC workstation in most cases. It's very important to understand that the image you send to the radiologist is the image that they are to read. It is the data that they receive. Acquisition and post-processing of images dramatically impact the radiologist's interpretation, and there is no storage of images on your X-ray equipment. What you send is what they read. Post-processing. The secondary function of image processing is to customize contrast in the region of interest. This type of image processing includes modifying the image to enhance the contrast and sharpness of some features while compromising the contrast and sharpness of others, as well as modifying the image to make it appear more like a film screen image. This secondary image processing is applied in a manner that is usually specific to the anatomic projection and the type of information we wish to receive. Misuses of image processing include compensating for inappropriate radiographic technique, compensating for poor calibration of acquisition and display devices, and surreptitious deletion of non-diagnostic images. Get rid of the evidence. Image processing to recover non-diagnostic images to prevent re-exposure should not occur. Routine reprocessing indicates a problem with automatic image processing or technical practice. Access to image processing software is essential to develop and maintain appropriate processing parameters. There are 5 steps that can help in the critical analysis to making an ethical decision. First, identify the problem. Next, develop alternative solutions. Then select the best solution. Defend your solution on the basis of the code of ethics. And finally, recognize your professional limitations. No code of ethics provides the answers to the dilemmas faced by the imaging professional, nor is a code of ethics merely a system of conduct. Ethics is a personal study and investigation. The purpose of the code of ethics is to present a framework for a systematic examination of beliefs that may lead the technologist to an understanding of personal and professional morality and responsibilities. Radiologic science professionals are legally liable for their actions in the daily performance of procedures and the management of their patients. These professionals must respect patient autonomy, and confidentiality must always be kept. All healthcare professionals have a responsibility to understand and practice the standards of care for their profession.